Dan Leonard, President of the National Pharmaceutical Council, and I'm pleased to be joined today by Dr. Mark Fendrick of the University of Michigan. He's a professor of internal medicine and health management and policy, as well as co-director of the Center for Value-Based Insurance Design at the University of Michigan. He also is the author of an important new document, a study by the National Pharmaceutical Council, Value-Based Insurance Design Landscape Digest. And in the digest, Dr. Fendrick defines the value-based insurance design concept, outlines key objectives and features for implementation, and provides real-world examples of existing VBID programs. Thank you very much for joining us, Dr. Fendrick. But before we get into the details of the report, Doctor, what was the initial motivation that got you interested in value-based insurance design and has propelled you along the way?
Well, our group has always been interested in the creation of health. And as you know, cost containment has really become the major impetus for healthcare reform. And we've tried very carefully to balance quality improvement and cost containment. Lo and behold, cost containment efforts put in place this one-size-fits-all approach for all diagnostic tests, doctor visits, and prescription drugs. And we felt all along that as cost containment became paramount, that health was being adversely affected. The creation of a clinically sensitive or value-based insurance design certainly acknowledges the fact that some clinical services may be more beneficial than others, and that if we could create a program that incentivizes individuals and health systems to do more of the right things, we could guarantee more health per dollar spent.
And that's really the crux of it, right? It's a very simple definition, as I understand it, increasing the value of health for every single dollar that goes into the health system.
Right. And imagine a situation where you walked into a retail store and every single thing cost exactly the same, regardless of its quality or its durability. There is not a stakeholder group that's not acknowledged to us that we understand that certain cancer screenings and certain medications for chronic medical conditions probably produce much more health per dollar spent than others. But most Americans face the same amount of out-of-pocket expenditure for every single thing they do in a given class. And I'll tell you that we've been very pleased to see most constituents get the intuitiveness of the value-based insurance design. And as the Landscape Digest reports, we've had adoption by private companies, health plans, and unions.
One of the examples I've heard you talk about, Doctor, and is in the digest, is around colorectal cancer screenings as an illustration of how VBID can and should work.
The principles of VBID are basically two. The first is to acknowledge the fact that all medical services are not created equal, although the typical benefit package that Americans have in their health insurance would suggest that every doctor visit, every screening test, every drug would cost the same. Colorectal cancer illustrates the second key point, that even if you determine something to be a high or low valued service, it really depends on who gets it. And in this example, Dan, a first-degree relative of a colon cancer sufferer should actually be paid to get a colonoscopy, because the risk of this disease is so high, and as you well know, the cost of treating it has grown up expansively in the past few years. A 50-year-old should get a colonoscopy for free. A 23-year-old without a family history of colorectal cancer, that person should pay 100% of the cost of that screening test, because there is no evidence whatsoever that this patient would benefit from getting an invasive test. On top of that 100% coinsurance, I would have that patient be fined $500 for taking his or her mother's slot.
Well, that would get their attention,
I think it would.
But it's also based on that evidence, and that's
right.
The key component.
Right. 23-year-olds don't get polyps, which are the reasons why we do colonoscopies in the first place.
But so much right now in Washington, in the middle of this really heated healthcare debate, but you've identified we've got one side of the bridge is focused on quality, and the other's focused on reducing cost. But it seems like in the debate right now, cost is winning the day, or at least that's where all the attention is.
Clearly, as much as you mentioned this span between quality improvement and cost containment, if this were any other sector of the American economy, I think we would come together and have a kumbaya moment over value. For reasons that remain to be explained to me, cost containment is the driving force behind healthcare reform. I personally think that we're asking the wrong question. Instead, we should be asking how best to invest in health. The same way we make the question, how should we invest in transportation, defense, or other aspects of our economy, if we took the good that we want to buy, which is health, into that perspective, I think the value proposition would be much easier to get through the turmoil and tumult of the political process. People are getting this, and as the landscape document reports, we're very fortunate to say that we have stakeholders from management to unions, from Republicans to Democrats, from the AARP to physician groups and patient advocacy groups that understand that production of health and maximizing health per dollar spent is a universal, acceptable, and achievable goal. It just takes a little bit of courage, momentum, and the political forces to get behind this, and we have some momentum to date, as you know, and it's growing.
There are multiple approaches to VBID. Could you explain what some of those different approaches that large employers are taking?
I think one of the key things that we try to make very clear in the Landscape Digest is there is no one VBID plan. It really does depend on the cultural context and the needs of the various organizations that are trying to get more health from their healthcare expenditure on their benefit design. The early implementation of VBID is to identify high-valued services and make them less expensive or in some cases free. Colorectal cancer, for example. This would be a situation where everyone got a lower copay. The same holds true for certain classes of medications, where people who would most benefit from them would get the same decrease in copay as those who may not benefit from them at all. Which is why the second, and I like this a little bit better, the more tailored type of VBID programs that don't just only look at services, but look at clinical conditions. For instance, eye exams would be less expensive for people with diabetes who have a much higher risk of blindness than those who don't have diabetes. Certain medications in certain disease classes, like beta blockers, would be free, or even patients would be paid to take them in the case of heart failure, but would get a reduction, but not to the same extent if they were taking them for something less substantial, like angina or asymptomatic heart disease.
And what about designing programs based on disease management participation?
Right. And as I said, because there is no real VBID plan, there have been other organizations that have basically said, as opposed to just because you have this condition or need this service, you get it at a lower price, there is this need for accountability or skin in the game. And some organizations have said to get your copay relief in the VBID program, you have to opt in. You need to see a health coach. You need to see a pharmacist. You need to enroll in our disease management programs. Some people give the copay relief up front. Others require certain thresholds to be met, like you did go through those programs, you did get the goal with your blood pressure, or you did certain amount of steps in your program to ultimately get that benefit design. We're very encouraged by the fact that there is not only one VBID experiment going on in the U.S., there are several, and it's our goal through the Center for Value-Based Insurance Design to find those various pieces that work best to bring quality and cost to the system.
And in the last minute that we have or so, the next big step would seem to be going into public programs like Medicare. How do you crack that?
Well, tough nut to crack,
yeah.
As you'd say. I think that the fact that we've got the Medicare Payment Advisory Committee on board, as well as some high-ranking members on the committees that oversee Medicare, at least interested in the idea. But as you know, most of the time the public programs look at the private sector as the laboratory, and I think that we've had several key constituencies agree that it's time to restore health to the healthcare cost debate.
Well, thank you very much. Fascinating report. Salute to you and to your center for the ground that it's been moving forward, and we're pleased to, at NPC, to be partnering with you on this important digest.
Well, thank you, Dan. The NPC has been a great collaborative organization, and the digest reflects our common interests.
Terrific. Thank you very much, Dr. Mark Fendrick.